Welcome back to the Therapeutics Chronicles. I'm your host, Momin Wali, and today we're exploring one of the most widely used oral antibiotics in community practice, Cephalexin. It's a drug that appears constantly in urgent care, walk-in clinics, dental practices, primary care, and outpatient antimicrobial therapy. And despite how familiar it seems, Cephalexin is also one of the drugs most frequently misprescribed, especially when it comes to dosing, duration, and matching its spectrum to the right infections. If you work in pharmacy or medicine, you know the pattern. Prescribing Cephalexin for infections it doesn't cover, using too low a dose for skin infections, giving it for urinary infections that actually require a different agent, or mistaking its safety profile with later generation cephalosporins. Misunderstandings are common, and because this drug is prescribed so often, these small mistakes can have real consequences. Today we're going to go through Cephalexin in a practical, clinical, and easy to apply way. Its mechanism, spectrum, dosing strategies, pitfalls, safety considerations, drug interactions, and the real-world cases that expose the patterns clinicians need to avoid. And near the end, I'll walk you through a dream counseling simulation tailored specifically for Cephalexin. Before we get started, if you're not already part of our learning communities, you are missing a lot. Join our WhatsApp and Telegram groups for real-time clinical discussions. You will find the links in the description. And if you haven't already, subscribe to the channel, share this episode with colleagues, and connect with me on LinkedIn so you stay updated on new episodes, clinical pearls, and upcoming content. Let's start by looking at what Cephalexin actually is. Cephalexin is a first-generation cephalosporin, part of the beta-lactam family. That already tells us a lot. It means it works by binding to penicillin-binding proteins and interfering with bacterial cell wall synthesis. Without a rigid cell wall, the bacterium can't survive osmotic pressure and eventually ruptures. Like most beta-lactams, Cephalexin exhibits time-dependent killing. So what matters most is how long the drug concentration stays above the minimum inhibitory concentration. The spectrum of activity for Cephalexin is both a strength and a limitation. It's fantastic against gram-positive organisms, especially Staphylococcus aureus, including many MRSA strains and Streptococcus pyogenes. This makes it a frontline agent for uncomplicated skin and soft tissue infections, cellulitis, impetigo, and follow-up therapy after intravenous cefazolin for methicillin-sensitive Staphylococcus aureus infections. But Cephalexin does not cover MRSA. It does not cover anaerobes. It does not cover atypicals like mycoplasma, and it only has modest activity against some gram-negatives like E. coli, Proteus mirabilis, and Klebsiella. Even then, resistance among urinary isolates is increasingly common. So one of the biggest mistakes we see is using Cephalexin for infections that require broader or different coverage. For example, acute pyelonephritis, diabetic foot infections with anaerobes, post-bite infections, or MRSA suspected skin infections. Cephalexin is inappropriate for all of these. But in the right scenario, with the right organism, Cephalexin is a powerful option. The dosing of Cephalexin is where we see some of the biggest discrepancies between guidelines and real practice. Let's go through the essentials. For uncomplicated cellulitis, the recommended adult dose is typically 500 mg 4 times daily, or in some protocols, 1 gram 3 times daily. Using 250 mg 3 times daily, something we still see often, is significantly underdosed and increases the risk of treatment failure. For confirmed streptococcal pharyngitis in adults, Cephalexin is usually reserved for penicillin allergic patients, and the dose is often 500 mg twice daily for 10 days. In pediatrics, the dose is around 25 to 50 mg per kilogram per day, divided 2 to 4 times daily, depending on the indication and the severity. For uncomplicated cystitis, Cephalexin is sometimes used, but it is not first line in many guidelines due to rising resistance. If it is used, typical dosing is 500 mg twice daily or 250 to 500 mg 4 times daily for 5 to 7 days. However, local antibiograms should always guide therapy. For skin infections in children, doses of 50 mg per kilogram per day divided every 6 to 8 hours are common, and in more severe cases, even 75 to 100 mg per kilogram per day may be used. Cephalexin is renally cleared, so in significant renal impairment, extending dosing intervals is necessary. For example, with a creatinine clearance under 30 milliliters per minute, dosing twice daily instead of 4 times daily is often recommended. Let me give you a classic real-world dosing error. A patient with non-purulent cellulitis is given cephalexin 250 milligrams 3 times daily. They return 48 hours later, worse than before. This is a classic underdose. Cellulitis needs high doses to saturate penicillin-binding proteins adequately. A proper regimen would be 500 milligrams 4 times daily, or in some settings, 1 gram 3 times daily once corrected. The patient typically improves quickly. Now, let's take a look at the safety profile. Cephalexin is generally well tolerated. Gastrointestinal upset is the most common side effect. Nausea, diarrhea, or mild abdominal discomfort. A mild rash can also occur. Because cephalexin is a beta-lactam, it carries a small risk of hypersensitivity reactions. True immediate allergies can involve hives, wheezing, or anaphylaxis. But here's something important. The cross-reactivity between penicillin allergies and cephalosporins like cephalexin is much lower than traditionally believed, especially when the penicillin reaction was non-anaphylactic. However, a patient with a true IgE-mediated penicillin allergy should be approached cautiously, especially if the reaction was severe. The risk isn't zero, but it's lower than commonly assumed. For non-severe reactions like benign maculopapular rashes, cephalexin can often still be used safely with proper assessment. Rare but serious adverse effects include C. difficile infection, although cephalexin carries much lower risk compared to antibiotics like clindamycin, fluoroquinolones, or broad-spectrum cephalosporins. There are occasional reports of liver enzyme elevation or blood dyscrasias, but these are extremely uncommon. There are few major drug interactions with cephalexin, but a couple are worth noting. High-dose cephalexin can interfere with metformin excretion, though clinically significant interactions are rare. It can enhance the anticoagulant effect of warfarin in some cases. So INR monitoring may be required during concurrent therapy. And as always, the conversation about oral contraceptives and antibiotics is ongoing. Although the evidence supporting reduced contraceptive effectiveness is extremely weak, many clinicians still discuss backup contraception out of caution. Now let's go through a few real-world cases to illustrate where cephalexin shines and where it fails. In the first scenario, a 28-year-old presents with classic cellulitis, warm, red, spreading area on the lower leg, clearly non-purulent. They are given cephalexin 250 milligrams twice daily. This is inadequate. The infection worsens. Once switched to 500 milligrams 4 times daily, the patient improves rapidly. This case illustrates the common underdosing error. In the second case, a 40-year-old woman is treated with cephalexin for what is actually a dog bite. 3 days later, the infection worsens. The issue isn't the dose, it's the drug choice. Bite wounds require coverage for anaerobes and pasturilla, which cephalexin does not provide. In the third scenario, a patient with a history of mild childhood penicillin rash needs an antibiotic for streptococcal pharyngitis. The clinician avoids cephalexin completely and prescribes azithromycin. The result? Treatment failure due to increasing macrolide resistance. After reviewing the allergy history and confirming the rash wasn't urticarial or IgE mediated, cephalexin would have been the safer and more effective option. In the fourth case, a pediatric patient is treated for cellulitis but receives a teaspoon measurement instead of a proper weight-based suspension dose. The child effectively receives only half the needed daily amount. Counseling the caregiver using a proper dosing syringe and explaining the exact volume leads to rapid improvement. Now it's time for the dream counseling portion. Before we begin the simulation, let me explain the dream framework for anyone new to it, because it's incredibly helpful in fast, clear patient counseling. DREAM stands for Direction, Reason, Expected Onset, Adverse Effects, and Monitoring. It ensures that every patient leaves with a clear, structured understanding of their medication. Let's simulate cephalexin counseling for a patient being treated for cellulitis. So you'll be taking cephalexin 500 milligrams 4 times a day. Try to space the doses evenly during your waking hours, morning, midday, late afternoon, and evening. If you miss a dose, take it when you remember unless it's close to the next dose. We're using cephalexin because it's very effective against the bacteria that commonly cause skin infections like cellulitis. You should begin noticing improvement in swelling and redness within 48 hours, and pain should gradually improve as well. Mild stomach upset is common, and diarrhea can happen. But if you experience severe diarrhea, a widespread rash, rash, or difficulty breathing, you need to stop the medication and seek medical care. Keep an eye on the size of the red area. If it keeps expanding after 48 hours, or if you develop fever, chills, or worsening pain, you need reassessment. That's the dream method. Simple, efficient, and comprehensive. Let's do a quick knowledge reinforcement. Does Cephalexin cover MRSA? No, it does not. Should Cephalexin be used for bite wounds? No, it lacks anaerobic and pasteurella coverage. What is the typical adult dose for cellulitis? 500 milligrams 4 times daily. Is Cephalexin appropriate for streptococcal pharyngitis in patients with mild penicillin allergy? Yes, it often is. To wrap up, Cephalexin is a highly effective, highly reliable antibiotic when used correctly and matched to the right infection. Its simplicity is exactly why it is so frequently misused, often out of habit rather than guideline-based decision-making. With the right dosing, correct indication, and proper counseling, Cephalexin remains one of the safest and most valuable tools in outpatient antimicrobial therapy. If you found this episode helpful, subscribe and share it with your colleagues. Join our WhatsApp and Telegram groups for clinical cases, discussions, and learning support. This is Momin Wali signing off. And as always, catch mistakes before they catch you.